leave meeting.
Welcome back to the Blair Technique Podcast. I'm Dr. John Stenberg. I'm your host for today, and we're going to do another episode that is a little bit different than technique based conversations, but we're going to talk about a condition that finds its way into a lot of upper cervical offices. And I've got with me Dr. Cameron Bearder from Keystone Upper Cervical Spine Clinic. And we've done at least one other episode on a condition and a couple others just chatting about clinical practice. So go back and check the episodes with Dr. Bearder. The last one was called Demystifying Meniere's Disease. So there's a little bit of overlap with this particular episode. But this time we're going to get into cervicogenic dizziness. And Dr. Bearder and I have talked about this offline. And one of the patient profiles that I've, just being honest, felt less confident in over the years that I've been in practice are all these dizziness conditions and all the different ways that presents. And so some of the things we're going to talk about today are how to understand when you've got one of those dizziness cases that you're just going to knock out of the park because it's cervical spine oriented, and how to do a good job of both screening that, of treating it, and then also talking about it with the patient and helping them understand what the problem is. So just kind of my disclaimer on this, when we're talking about conditions and we're talking about symptoms and we're talking about medical diagnoses and things like that, I think it goes without saying, but it's worth mentioning that we're not necessarily suggesting that upper cervical chiropractic is a cure for these things. And obviously the goal of upper cervical chiropractic is to detect and correct an upper cervical subluxation. But these subluxated people have a lot of different symptoms, and a lot of the symptoms related to the subluxations can be confused with other conditions. And so a big part of our job is helping to, create some order out of the chaos for folks and help them understand what we're actually doing and how we can actually help them. So anyway, with that preamble out of the way, Doc, if you want to do a quick intro, maybe talk about your background with this topic and how you've come to the level of understanding that you have, I think that'd be helpful. And then we can get into the nitty gritty details.
For sure. That was a great preamble, by the way. I don't really know that we have much to talk about after that, but yeah, so cervicogenic dizziness. This is something that I've been thinking about for a long time, well before I got into the functional neurology side of things. But when you're in school and you hear about upper cervical and you think, okay, who's going to present with something like this? It's dizziness just kind of makes sense. And so probably similar to you, I had some good experiences, some good success, and maybe some not good success. And for various reasons, I wanted to dig a little bit deeper. And so, I've done quite a bit extensive training with vestibular conditions, and cervicogenic dizziness is something that has been quote controversial in chiropractic. And if you look at the literature, it's sometimes oh, it doesn't exist, whatnot. But yeah, we've had pretty good success when it comes to cervicogenic dizziness, or what I believe would be considered that. So you and I have talked about this, like you said, offline, and I think it's a good topic to go into. Yeah, but controversial for sure. And I think a little background. In the 50s, apparently this is when things first kind of came up, when it was discussed, and I'm not 100% confident as to why it's been controversial. I think probably because there's no actual definitive, like this is the one test to distinguish cervicogenic dizziness from other things. But I don't know that there's a distinguishable test for anything, so to say. But yeah, chief complaints are going to be imbalance, unsteadiness, disorientation. And the key differentiator here is probably going to be neck pain with limited cervical range of motion and potentially a headache. So that puts it right here in this upper cervical type approach. The big thing here, because we have done a previous podcast on Meniere's disease, there are some Venn diagram crossovers, and that cervicogenic dizziness typically is not going to include that ear fullness, typically isn't going to include tinnitus, typically isn't going to include hearing loss. So when we talk about the diagnostics or the history, excuse me, these are the things that you're going to want to check off in terms of, okay, do they have that hearing loss? Is it been clinically diagnosed? Is it just perceived hearing loss? Do they have the tinnitus? Do they have the ear fullness? And so I think you and I both have agreed on multiple accounts in that, excuse me, the history is probably the most important thing to understand so that you can properly, quote, diagnose this person, or at least within your own walls. I don't want to say diagnose, but diagnose this person within your own walls. Does that make sense?
Yeah, and I think even if you don't feel comfortable with diagnosing, even categorizing,
Good word.
the
Yep.
sort of what's the word? Yeah, the category of dizziness that they're dealing with. And here's a couple things I was thinking as you're talking. Patients come to upper cervical doctors for various reasons, and they don't always tell us all the information. Sometimes they tell us what we think we need to know to treat them.
Absolutely.
And if they've got neck pain and that's the thing that they really want us to help with, they may not even mention that they're dizzy, right? So
Mm,
I think in the clinical history and your intake and just your consult or however you do that with patients, I think it's worth, when you see some of these symptoms, you ask about the others. They may not list it, but you can say, "Hey, do you get dizzy? Art, do you experience dizziness?" It can go both ways. If they only talk about dizziness, you can ask about the ears and the symptoms related to the neck, because those things might not seem associated to them, and they may not even bother to mention it. So,
yeah.
as you're going through your questioning of a patient and extracting of the information that you need, I think it's worth understanding some of these connections and teasing them out.
Yeah.
Now, if you're just gonna kind of go through your scripted version of like how upper cervical relates to this, that might not be as important. But if you have even a tech or somebody else who's taken a history or maybe filling in the gaps on this, I think it's important that you document, all the important information, and maybe, deviate from your script if you need to get the right information from the patient.
No,
Um,
absolutely. And that's, you bring up a good point there in terms of the right information. And it does come down to extracting the information from the patient. They may have done their quote research online and they may come in saying the right terms, or they may not. They may be just as confused as sometimes doctors are, because some of these terms appear to be interchangeable even though they aren't. But just kind of a blanket statement: vertigo and dizziness are not the same thing. They're
mm,
very different, and I feel like that is an important thing to say, as social media is a huge tool, and people are watching videos and getting into our offices. Vertigo and dizziness are very, very different, in that vertigo is true spinning. So, great question to ask a patient: are you spinning, or is the world spinning? If they say no, they don't have vertigo. Clear and simple, right? That doesn't mean that there isn't vestibular dysfunction, but that is not vertigo. And one of the big things as well is, if they say, well, I do feel like I am spinning, you can then start to ask, do you feel like you spin, or do you feel like you spin when you are moving your head, right? So we would then get into more of the positional type of feelings. So then you're looking, is it cervicogenic dizziness and or is it BPPV, right? Benign paroxysmal positional vertigo. Those two sometimes can be interchangeable within the patient's mindset, in that the head position is classically BPPV, but you would want to ask that patient, do you feel dizzy when you turn your head? And if they say yes, you would then ask, is the world spinning, or are you spinning when you turn your head? And if they say no, then we can maybe move into the classification or categorization of dizziness versus vertigo, right? And I think that's extremely important, because realistically, statistically, a chiropractic adjustment, or a chiropractic adjustment probably isn't going to affect BPPV, right? When we think classically of the otoconia and the crystals. So that's an important thing, managing expectations, so that can I help this person? And that the patient, or prospective patient, knows, can I be helped by this provider, right?
yeah, and it's so confusing for folks that, they're doing their research and they're trying to make sense of like their own suffering and
Yep.
get to the person that will help them. And a lot of these folks, I'm sure you've seen this too, have been to neurologists and ENTs and primary care providers, and they've done a whole bunch of different things a lot of the time, and they've been, confused every step of the way, because it's like
Mm,
the next thing seems like it'll help. And we've had folks that have done, they've had all kinds of, testing and MRIs, and
yep.
they've got this symptom, they've got this clinical sensation that they're experiencing, or this change in their physiology, and nobody can seem to identify, what the cause of it or what's going on. And they
Yep.
may have even been to vestibular rehabilitation or physical therapy or something like that too. And it's even hard for providers, is the part of having the conversation, to sometimes distinguish, what am I dealing with here? Because
Yeah.
of how the patient describes their symptoms and how they try to communicate what these weird things that they're feeling.
Yeah. Well, and it doesn't help that there is no definitive clinical test for cervicogenic dizziness, and that according to the research, it is more a diagnosis of exclusion,
Hmm.
which, you know, when you start to talk about vestibular conditions, and I know you've used this analogy, and I'm sure for the doctors or students that are listening, it's an easy analogy to understand. We have a hardware issue versus a software issue in terms of a lot of times vestibular dysfunction is a software issue, believe it or not, in that you have this vestibular system that has webs into almost every major system into the body. And so you have the software issue, which realistically, modern medicine and modern healthcare, we just don't have the technology and or the capacity to understand and image these things. You can't necessarily image vestibular function, not yet at least. You know, you can't get a good MRI on the vestibular nucleus, on the right-sided vestibular nucleus and how it talks to the cerebellum and the canal. So it can be very frustrating for the patient and the provider. And this is how people typically end up in our office. And again, I'm sure you've experienced this. You have someone who says, I've been to the neurologist, we did the MRI, I paid a lot of money, it was good. There was nothing there. That's great. You don't want something on your MRI. That's not good stuff. You then were sent to the ENT. ENT looks in the ears, looks at the eyes, hopefully, and everything's good there. So we're going to send you to vestibular therapy. Okay. I did 3 months of vestibular therapy. I looked at a dot. I shook my head up and down, left and right as fast as I could. I felt a little bit better, but I still get dizzy. I love it when these things come to our office because typically that's when we're going to knock this out of the park, because then we have the upper cervical subluxation, we have joint position error, whatever you want to call it, and there's a higher likelihood that this person is going to be helped within our office, because from exclusion, process of elimination, this person has already done everything and they've done the standard of care, and now here they are, and so we have the likelihood to hit that home run, which is exciting for both the patient and the doctor. But you still want to include, exclude, and you still want to make sure that you're doing the correct testing. And thankfully, the testing can be very low tech. You don't need to spend thousands of dollars on some of this testing. Realistically, only a couple $100 to adequately understand, is this coming from the neck versus not.
Before we get into the testing bit, a couple follow-up questions
Yeah.
for history. These are the things I was thinking about that I would want to ask a patient. With the onset of these types of symptoms, is it more likely to be a gradual onset and progression, or
Hmm.
can folks even have an acute episode of cervicogenic dizziness that can come on rapidly and be pretty intense?
Both. I would say both. Again, looking at the research and clinically, you could have the WADs, the whiplash associated disorders, right, and then everything that comes along with that. Or as we talked about offline, it can be this progressive in terms of you have deconditioning of the cervical spine and the musculature, fatty infiltration, arthritic change, all of these things that are going to change local and global proprioception. So, again, the history. Did you have an accident? Did you have a trip and fall? Did you have a concussion or a head injury? Or is this something that has been building over time? So, again, this is the history, the intake, the imaging, that type of stuff. That's a great question, and I think that's extremely important. That's, in my mind, that's kind of one of those things where you need to get that out there as fast as possible. Is this something that started boom like that, or is it gradual?
Good. Okay. So let's switch gears and get into the testing bit of it, because there's obviously, like you said, not necessarily a definitive diagnostic tool for this, but we can start to zero in on the cervical spine as a driver of dysfunction with this type of situation. So how do we start to tease this out a little bit? And I think we'll probably, just for the sake of time, exclude the chiropractic analysis side of
Okay,
it.
sure.
We could talk about some features, clinically, things you might see on a CT or
Yeah,
X-rays, but I think, let's just assume folks are going to do a good job with their chiropractic workup,
yep,
which from a Blair technique perspective involves, obviously your CBCT or your X-ray analysis, your Titron scans, your leg
yep,
checks, and all your subluxation findings.
yep,
What are some additional, testing considerations with this?
for sure. So the cool thing about this is, at least in my experience, is a lot of this can be performed in succession. So you can literally do one test after another, and it can be relatively not super time intensive. So, if you're running a busy office, either your tech can do it or you can do it in a short amount of time. Or you can get pretty detailed with it. You can go clinical in terms of you have some pretty interesting technology to where you can start to quantify the data, and you can now give this to the patient. If you are running an insurance practice and some of these carriers want to see evidence, you can now provide it. If you are co-managing with other providers that are non-chiropractic, you now have objective data that you can send to them. And it looks really freaking cool. Patients love to see this stuff as well, as much as they love feeling better. If they can say, I feel better, and then you can show them the change, you're really knocking this out of the park. But let's just assume low tech for now. You're going to need a swivel chair, which you can realistically buy off of Amazon for like $100. You don't need to get fancy. Ideally, you would want to have it adjustable, no pun intended, but you would want to have it adjustable in terms of it would want to raise and lower so that you can get their feet off the ground. And then you can do a motion guidance system, which is pretty common. Honestly, I would suggest that you don't do that, but it is something you can do. I would recommend laser glasses, particularly no disclosures from Cedric Noel with Nerd Solutions. Basically, it's a pair of sunglasses that have been retrofitted with a laser right in on the bridge of the glasses. I think that is the best because the motion guidance probably it's difficult to properly set it on their head, and you're assuming that it's placed properly. You're assuming that it's tight enough so that it doesn't slip and fall or it doesn't sag down. But the glasses are like $50. I love them. And so you're hitting the ground for $150, and you can basically perform the 3 tests, which, according to the research, would need to be performed to either rule in, rule out. And so you have the cervical neck torsion test, you have the smooth pursuit neck torsion test, and then you have the cervical relocation test. The cervical neck torsion is going to be seated in that swivel chair. Patient is going to be looking straight ahead. And essentially what you're going to do is you are going to have them keep their eyes open, and they're going to be looking straight ahead, and you turn that chair passively 90 degrees. So that neck is pretty cranked out. And you're going to hold it there for 30 seconds, ask about dizziness, right? Do you feel dizzy? Do you feel nauseous? Is the room starting to spin? And then you return the chair to center, ask the same questions. You repeat it going to the right. And in particular for the cervical neck torsion test, you would be looking for nystagmus, so involuntary eye movement, more than what would be considered 2 degrees per second. So you can kind of go down the rabbit hole with this one. What does nystagmus look like? What is out of the norm versus in the norm? What's acceptable? Realistically, the eyes may jump a little bit, but you shouldn't see what would be like clockable nystagmus in terms of those eyes are just beating, smooth move beat, smooth move beat, smooth move beat, right? And the patient will likely end up saying, oh yeah, I'm starting to feel really dizzy. So you'd want to correlate that. Next test would be that smooth pursuit neck torsion test. So it's kind of the further depth into looking at eye movements. This one actually has the research correlated with whiplash in terms of how neck movement and relative to eye movement can create dizziness. So same thing, you're going to want to basically turn that chair, and you would then have a patient look at your thumb or look at a fixed object, and you would move that object in the horizontal plane left and right. You don't want to move it super fast, but you don't want to move it super slow. You'd probably want to do both. And then you would ask, hey, do you feel dizzy? Is the room spinning? Do you feel disoriented? Things like that. What you're looking for here is left and right rotation. So we'd want to test that patient with the trunk head straight, but turning the chair to the left about 45 degrees, and then checking that smooth movement, turning the body to the right, and again, checking that smooth movement. And so what you're looking for is discrepancies in what's called gain. Gain would be smooth movement. So no quick jumps, no small jumps, no large jumps. Those would be called intrusions, saccadic intrusions. And then the next one, I think, is really the bread and the butter of what we would end up doing in our offices or traditional upper cervical practice, in the cervical relocation test. So This is when you would have that laser. So this would actually be more joint position error, but you would have that laser mounted on their head. They'd start in the center. They'd close their eyes. You would hold their head, and they would close their eyes, and you would turn the body. I'm sorry, no, back up. You would not hold the head. They would move their head in a flexion, extension, left and right manner. So, for example, all right, John, I'm going to have you look straight ahead. You see the lasers right there on the wall with a dot. You're going to close your eyes. You're going to tilt your head back. You're going to bring it back to center. You're going to tell me when you think you're at the center. Okay. And then you do that about 3 times. You would then do flexion, extension, you do left and right rotation. You can do other positions as well, but research is just showing those 4. And essentially what you're looking for is you're looking for that patient to get back into the center of that dot with the laser. So clinically, the research is saying that anything over 4.5 degrees would be considered abnormal. That's going to be hard to measure.
Yeah.
That's going to be really hard to measure. So you would kind of need ballpark that. You can get pretty technical in that you could have a graph or a bullseye with measurements there. But that one in particular is probably going to be the biggest bang for your buck, as well as the cervical neck torsion test and the swivel chair. And then less likely would be that smooth pursuit test. But those ones, I mean, you could do that within a matter of probably less than 10 minutes, and you can get great clinical information in terms of joint position error, and then you can correlate it with your subluxation findings.
Yeah, I'm thinking about how, let me just recap because that was a lot, and I think folks are going to be wanting to listen back or get more detail. Obviously, this stuff's probably all on YouTube somewhere, but I'm thinking about it this way because I have one of those Anderson chairs, so a lot of folks have a X-ray chair that swivels and supports the patient's feet. And I could realistically, take their CBCT, wheel them out, and go right into the cervical neck torsion test. So the idea is you're looking straight ahead. I'm going to turn this chair to 90 degrees while you keep looking straight ahead.
Correct.
Right? Are you feeling dizzy? I can then go back to 45 degrees and then look at their eye movements. I'm going to do both of those on the left, and then I can turn all the way to the right. Same thing. Go through the questioning. Are you feeling dizzy? Go back 45 degrees and then do the smooth pursuit test. So, even with the equipment I already have, in a couple minutes, it seems like that would be pretty easy information to start to gather.
Absolutely. The one thing that I would recommend if you are going to do it in that type of chair, be careful as how that chair in particular rotates. Because if you start, if you start rotating and now it's rotating off axis, so realistically, the neck is supposed to stay still and the trunk is supposed to rotate almost linearly under the body.
I see.
So I guess the caster system, right? The wheel casters, that would be a little bit, you'd have to be a little bit more careful there. But if you have, what is it, the Anderson, the actual the orthogonal type X-ray chair, that absolutely, you could knock that out of the park with that. And you could even do the cervical relocation test and the joint position error test right there as well. You just have to have that dot on the wall. So yeah, patient wouldn't even need to get up. You could do it right there and then. That would actually be really good from a flow standpoint. I love it.
Yeah, and just look around your exam room and try to figure out what's the easiest way for you to make this seamless. With your procedures, and not have to reinvent your exam flow, but just to take a couple minutes to get a little bit more information. And then obviously
on the wall.
Yeah, and then obviously these are things that you can recheck over time. You could recheck it post adjustment, potentially, or as outcome assessment in your progress exams.
Yeah.
Would you expect to see improvements with these things post adjustment?
That's a good question. I would say overall, yes, but there's a lot more that goes into that. But I do think that it is something that you should check post adjustment, regardless of what you are expecting or not. It will give you good clinical feedback, and it will help the patient understand as well in terms of, okay, this is going to be something that we can knock out relatively fast versus, hey, we know based on our CT that you've had arthritic change there, so our cervical range of motion is going to be reduced. So, we may need to co-manage with a physical therapist or a vestibular therapist depending on what else is going on. But realistically, sure, I think that it could be another indicator of pre and post subluxation check and pre and post adjusting that, that's not going to cost you anything extra to do. I think it's something that would be a really cool post test to do.
One of the notes, from the document you sent me, and I want to just kind of tease this out for when folks
Yeah.
are doing these procedures. Provocation of dizziness with the trunk rotation under a head stabilized in place implicates the cervical spine, whereas dizziness with the head and trunk rotation together indicates a vestibular component to the patient system.
Yep, that's a good one.
So explain that in a little bit more detail. And it kind of seems obvious when you think about the
Yeah.
anatomy, but maybe break that down so folks,
Yep.
in the event that they maybe perform the test incorrectly or forgot exactly
Yep.
what to do and elicit a symptom, how
Yeah.
to understand what they're seeing.
No, that's a good one. So the provocation of dizziness with the trunk rotation under a head stabilized, so that would be that cervical neck torsion test, right? So the head is staying still and the trunk, the body, the shoulders, and the pelvis are all rotating under, versus when the head and the trunk are rotating together. So when they're rotating together, that would be more of what's called a time zero. Okay, so that is going to be more canal based. So when the head and actually when the head rotates, you are getting more vestibular, so classic vestibular input from those horizontal canals. You may end up, depending on how much you're going to look into this, if you did want to test it, you can kind of get into the weeds with this, but you could do a time zero, which would be the head and the body rotating together with the eyes in, let's say, a rightward rotation. That would be more of a time zero. Or what you can do is you can have the patient keep their eyes fixated on the target, and then you are rotating the head and the trunk independent
Of the
of
eyes.
of the eyes, and that would be more of a time zero. So that would give you an idea of, do we have a decrease in vestibular gain? Do we have an increase in vestibular gain? And so that can tease out is this cervicogenic, and or is it cervicogenic and more of a true vestibular dysfunction? So
Yeah.
Yeah.
The point I wanted to make there is that you don't want to go the positioning the body with the swivel chair while leaving the head still is not the same as turning the head. And that's the
Correct.
point I
Very
wanted to make,
different.
because
Yep.
those canals in the head are going to be activated with head motion,
Head motion.
but you can turn the neck while keeping the head still by rotating the trunk. That was the point
Yep.
I wanted to,
Yep.
folks to get, and hopefully that was obvious. But the key with that is, like, you're not wanting to activate those canals
Correct.
when you're performing, these tests, so that you can isolate the cervical spine independent of the canals.
Yep.
And tease out the symptom that way. So
well, and just for comprehensiveness sake, it probably wouldn't be bad to do both, because there could be actually, it probably is statistically likely that they are experiencing some sort of vestibular dysfunction from the vestibular nucleus or whatnot. So it would be good to have that data in terms of, was it purely cervicogenic, and or was it cervicogenic and some sort of true vestibular dysfunction? Because again, you want to make sure that you're doing right by this patient. If that true vestibular function doesn't resolve, you're probably going to want to send them to someone who's going to be able to help resolve that. So again, isn't going to cost any money, and it's probably not going to take too much more time, maybe an extra 30 seconds. You might as well do both.
Yeah, and I mentioned this to patients on occasion when they get frustrated with chiropractic not being the only thing that can help them. And I think back to Dr. Carter, who taught us advanced imaging at Life University. He used to say, patients are entitled to more than one problem. We don't have to, always isolate and identify one particular thing as, it's this terminology is out there in just the natural health world, but the root cause, right? Everybody loves to talk about the root cause. And even by that analogy, it's like, what plant has one root, right? Like, there's often networks and webs of roots, and they interact and they intersect. And I think, even if that terminology resonates with you and that's something you like to talk to folks about, just be mindful that there can be more than one thing going on. And it doesn't detract from the value of upper cervical care, but for the sake of the patient's suffering, it might be worth, supporting them with a referral or some additional therapy if that's in your wheelhouse.
Yeah. No, it's that. I mean, it's a perfect analogy. The neck is connected to the head, connected to the rest of the body. There's probably something else going on, and it like we've talked about before on this podcast and offline, it truly comes down to what do we think we can do, because it's, as you like to say, putting the care back in healthcare, and I think that's extremely important so that the patient gets the result they're looking for. And it's funny you say that they're entitled to more than just one thing, entitled to have more than one issue. When it comes to the vestibular system is likely the oldest system in the body and on the planet. When you look at the data of what they think, the proverbial they, what they think was the first version of the vestibular system, it was jellyfish. Is the otolithic system, which is more translation. And then as we evolved and we needed to rotate for various reasons, safety and things like that, now we have this horizontal canal system. So you could have a discrepancy in those systems right there. It could be all three of these systems: cervicogenic, otolithic, vestibular. And whether it's in your warehouse or not, you're gonna need some sort of understanding of, okay, is this something that the upper neck is going to help with? And it very likely could. You and I both know the craniocervical junction is the powerhouse. Um, there's what was this? I think you had Dr. Scally on the myodural bridge. That's something that was just discovered within the past 10 years. We're finding this stuff out every single day. So pretty cool, pretty interesting.
Yeah, and this might be a little bit of a sidebar, but I know there's often confusion about even the anatomy and some of the terminology related to these different systems. So I think it would be worth defining a couple terms, just so that folks are reminded of what they learned in chiropractic college, however long that was ago, or if you're there right now.
Yeah,
So maybe in no particular order, canals. And maybe that seems rudimentary to you, but I think it would be worth explaining to folks, what are you talking about when you refer to canals, but
yeah,
then also otoliths, and some of the other terminology related to these systems.
yeah, for sure. Yeah, the basics are the canal, semicircular canal. So there's three on each side. They could be interchangeable in terms of you have the anterior or superior canal, your horizontal canal, and then your posterior or inferior canal. And these guys are bones. I mean, it's literally a permanent sense of direction. These bones don't change. There can be pathology within the bones, but within the bone there is fluid, right? And that fluid moves based off of movement. So think of it like a water bottle. If you have a horizontal water bottle and you move it side to side, that water is going to create an interaction with the bottle itself. And then you have otoliths, which are a little bit harder to understand. And those are a little bit lower. And then you start to have the cochlea. So, everyone can Google this type of stuff to get a better understanding. But for the most part, we're probably going to end up focusing more, at least in the upper cervical world. The dysfunction that we see is probably going to be more otolithic based. As well as cervicogenic, maybe cerebellar. But yeah, it's a complex symphony of this system and how it relates. You have that. So what we just talked about is the peripheral system,
Yeah.
which is classically what is treated within the medical model. And then you have the central system, which is now the vestibular nucleus in your cerebellum. That's a little bit harder to distinguish, but it's still extremely important because an adjustment has been shown to stimulate certain regions of the brain and the periphery to help with these conditions.
Exactly, and I wanted to kind of differentiate central versus peripheral because,
Mm,
we like to think of things, everything as the central nervous system, right? But
yep.
that's not always the way that other healthcare providers might look, especially ENTs, right?
Yeah.
So when they're talking about the vestibular apparatus or some of this stuff in the skull, we're talking more peripheral. When you're talking, vestibular nucleus and some of those, brainstem
Yep.
structures that are neurological, it's a little bit different. So even the word vestibular can mean different things depending on, where you're looking at it
Yeah.
from.
Hardware versus software, like we talked about. The hardware is going to be that peripheral vestibular system. The software is going to be the inner, and they talk to each other, obviously, and one can't really survive without the other. And if they do, well, there's probably some sort of compensation. But uh, I don't remember the exact statistic, but I do know that it's over 80% Most medical approaches are going to 80% of the time are going to take the peripheral. It's extremely difficult to identify a central vestibular issue. I'm actually unaware of anything that can accurately diagnose that. There's kind of these indirect ways, but when you go to the ENT, hopefully they're going to do some sort of neurovisual exam, video oculography, VNG as well. And then you have the calorics, which are a lot of fun for patients if they've ever had that. That's putting warm and or cold water, air into the peripheral vestibular system, which is going to actually elicit a central response. And then you have the VEMPs, cervical VEMPs, which is putting electrodes on the sternocleidomastoid. And those are different in terms of the nerve function. You have the superior and inferior vestibular nerve. So we can get into the weeds with this, but it is good for the upper cervical doctor to understand that this can be a lot more complex than just cervicogenic.
Well, and patients will sometimes say, and I've had a lot of folks say this, and when they even say it, you can see on their face, they're like, I don't even know what this means.
Yep.
Right. And they'll say, like, yeah, I went to the doctor and they told me I got the crystals in my ear stuck.
Yep.
And they're like, I don't even get, what that means.
Yeah.
So how would you help a patient understand what
Sure.
that terminology means?
Yeah, that's a fun one. The whole crystals in the ear. Dr. David Traster at the Carrick Institute really kind of opened my eyes to this in terms of that. That is actually a singular theory that has been, I don't want to say disproven, but it has not been solidified the way we've been led to believe, and that you have these calcium carbonate crystals, or that are technically called otoconia, that can be dislodged and then float around in the canals. But the funny thing about this is the fluid within the canals is like molasses. It is not a water type fluid. And then you have these otoconia, which are realistically like little grains of sand. Um, the research on this has actually been largely inconclusive in that they've done autopsy studies of people who have had lifelong vestibular, BPPV type symptoms, and then people who have not had any vestibular symptoms. And guess what they find? They find that there have been otoconia in the canal the entire time with both of these scenarios, people with BPPV and people without it. And so this is when we start to look at the central versus peripheral mechanisms. And there is always going to be a central mechanism to the peripheral condition. And this gets me really excited in that when you adjust someone's spine, you are going to have a central effect. This is one of the probably sub reasons why we can help some of these weird conditions, vestibular conditions that haven't been helped otherwise. So there's kind of pros and cons here. But yeah, BPPV is largely going to be positional in terms of when a patient puts their head in a particular position, okay, you are going to get rotational symptoms, so spinning. And then you could have cupulo versus canalolithiasis. Does it last for more than 60 seconds or under 60 seconds? And you can differentiate there. But that's a big one for the docs and the students to understand, and even the patients, prospective patients listening to this, is when you put your head in these different positions, do you get the spin or do you just get dizzy? Does it dissipate? Does it stay? That's extremely important from a management standpoint.
Yeah, and I'm thinking of a couple patients that I've had describe, when you're talking to them about like, how did this start? Now I've
Yep.
had folks say, I was laying in bed and when I woke up and I rolled over onto my side
Yep.
and the room started spinning.
There we go.
Right. So like these are where these things hit, become real world, the real world application and ways
Yep.
that you might talk about this with patients. Or
Yep.
I sat up and the room started spinning, right?
Yep.
Versus I felt a little lightheaded,
Yep.
versus the room started spinning, right? So there's different ways to tease this stuff out.
That's extremely important. And this, I'll be speaking at the Blair conference on vestibular dysfunction, but the lightheadedness is a huge, huge thing in that we now have rotational symptoms that need to be differentiated. You have potential cervicogenic symptoms, and now we have lightheadedness. Classically, lightheadedness actually is going to be some sort of orthostatic and or vascular issue, right? And that might segue us into the red flags and considerations. But lightheadedness can be cervicogenic. It also can be vascular. It can be a combination of the both. But whenever you hear lightheadedness, you want to ask the patient, Are you lightheaded when you're turning your head left and right? Are you lightheaded when you're going from laying to seated or seated to standing? If they're lightheaded when they're turning their head left and right, we probably have more of a cervicogenic component. If they're getting lightheaded when they're changing position from laying to seated or seated to standing, we probably have some sort of autonomic concomitant in that we may have a postural issue, we may have a vascular issue and insufficiency. And as you and I have talked about offline, it may be in the lower leg, right? Have them do some calf raises, have them do some sit to stands, get that increased peripheral resistance to get that blood from the lower extremity up to the brain, and that may help things tremendously.
Yeah. And so it's again, you can get yourself all turned around, trying to make sense of all this stuff when you're sitting
There's a
there in
pun
front of a
there.
patient. Yeah.
There's a
When you're
pun
sitting
there.
there in front of a patient and they're trying to describe to you what's going on with them. So
Yep.
just trying to, because this is how I feel sometimes, just being honest. I don't have the training that Dr. Bearder has, but I've, had a lot of conversations with him about this stuff. So as I'm building my knowledge base and my
Yep.
understanding of these different systems and conditions, I can relate to folks that are listening going like, oh my God, this is a lot. I
It
don't
is.
even know if I've got it all straight. It's okay. Just continue to
Yep.
revisit the concepts, and it's like this with our patients. We educate them over time because it's not obvious the first time, right? And
Yep.
there's that old adage, I don't know where it comes from, but you have to be exposed to an idea 7 times before
Something
you
like that.
really start to grasp it. So for folks that are feeling a little overwhelmed, it's okay. This is just becoming more familiar and having more interactions with these conversations will help you make sense of it. If you go back
Even
to the podcast I did with Dr. Chung, talking about the intersection of functional neurology and upper cervical chiropractic, he had made a comment there that he likes NUCA in an orthogonal analysis system for upper cervical subluxation because of how that can impact canals. And
yep.
so you can get into the nitty gritty details on this
Oh
stuff,
yeah.
but the impetus for all of us as upper cervical doctors is do an excellent job of your chiropractic upper cervical analysis and adjustment so that you're putting the proper input into the system, you're getting the proper structural and mechanical changes, and you have a reliable way to track progress based on what we know to be true about upper cervical chiropractic. And then this other information will fill in the gaps on the symptoms and the other systems that are potentially involved so that you can manage the patient's case.
Yeah. And that's, that the kind of thinking at what you just said in terms of feeling overwhelmed, if you're a young doc or even a seasoned doc who wants to know more, student really, it all of this stuff is already out there. It can be a little bit difficult to compile, but there's some of the landmark research papers literally have tables that you can print out and you can then put that into your initial intake paperwork. And essentially, the patient will basically diagnose themselves through the history, and you will then just have to tease it in, rule it out. So trust me, it can be extremely overwhelming. But the good news is a lot of other people have already done this. So that's something that I'll probably end up doing for the Blair presentation at the conference is just a quick checklist of ask these questions. If this, think that. If this, think that. If this, get them out. So it's important for sure. But yeah, I understand the feelings of overwhelmness.
Well, speaking of get them out, let's talk about maybe some of the more serious red flags for dizziness conditions, because
For
there's
sure.
there are some really serious things that could be contributing to a patient feeling dizzy, and for whatever reason they might find their way into your office first. It could be a
Yep.
patient that's already been under care that has a new problem come up, and they become good. God, doc, I need to be adjusted. I feel like crap. I'm dizzy. Like all this other stuff. So let's get into some of the red flags and vascular considerations with dizziness that may be a situation where you need to get them help ASAP.
Yeah. No, for sure. Do you want to start with that?
Yeah, go ahead. Let's talk about the blood vessels, and
Mm,
because there's a lot of really important, vasculature in the head and neck. That's not only important for symptom etiology, but also for emergent situations.
yeah.
So let's distinguish some of the different vascular tissues around the head and neck, and times where you've got a serious problem on your hands.
Yeah. In my experience, for the most part, and I think this is fairly accurate, it is extremely unlikely that someone is going to present to an upper cervical office with a stroke in progress, right? We've all seen the stories. We've seen them on the news. Our malpractice providers have warned us. The statistical likelihood is very, very low, but you would want to ask something along the lines of, have you ever experienced this before? Have you ever had vertigo? Did it just literally, you minding your own business and all of a sudden, boom, you got vertigo? Did you drop to the floor? Did you start to have these neurological symptoms? Did you lose your vision? Your vision get blurry? One of the things that, getting into the weeds just a tiny bit, you have these uh, picas and icas. So you have posterior inferior cerebellar artery, you have anterior inferior cerebellar artery. These are typically where these strokes are going to occur. But from the neck, we're definitely going to have those jugular, carotid, vertebrals, and things like that. And so the biggest thing that I would do in terms of asking the question is, have you ever had this before, right? How did this start? Were you minding your own business, or did you roll over in bed? Um, did you have neurological symptoms and that you had blurry vision? Did you lose your vision? One of the big ones that I was taught was, did you see the world quickly flash upside down and then go back to normal? For some reason, and I'm sure that there's the data out there, but for some reason that is indicative of some sort of probably stroke. But you're going to want to look at these DTR, the DTRs, the deep tendon reflexes, the upper neurological signs, upper neuron signs, and then the cranial nerve function. You're going to want to do sensation, right? Pinwheel, soft. Uh, probably, it would be smart to have them turn their head before you ever adjust them, before you ever do anything. Have them turn their head, maximal rotation. Ask about symptoms. Does your vision go blurry, right? Do you start to feel dizzy? Do you start to feel nauseous? Things like that. You're going to want to do pupillary light reflex. You're going to want to shine even your phone. Get your phone out and take put that flashlight feature on and shine that into their eyes. You're going to want to look for the pupillary light reflex. If those eyes do not constrict, get them out immediately. Get them out. Send them to the hospital. Call the ambulance. Do what you need to do. That one probably in particular is the biggest one. If those pupils are unresponsive to light and you're sensing that there's some other neurological symptoms, get them out. Don't take your imaging. Don't lay them down. Don't palpate. Get them out.
Yeah, have them live to adjust another day, right?
Yeah, there we go.
And not have permanent limit issues because of that, or
Yep.
be part of the post-stroke rehabilitation process. But
Yep.
yeah, and we talked about this in the Meniere's paper, the episode when we discussed the Meniere's papers too, and there's ways that you can even do some of these tests and look at that pupillary light reflex and see, do
Yep.
we have reactive pupils? Okay, we're probably thinking there's less vertebral basilar insufficiency going on. And
Yep.
so when you talk about the picas and the icas, your vertebral arteries, as they go up into the skull and feed into that basilar system, the circle of Willis and all that collateral blood flow through the brainstem and lower brain, that's the system we're talking about. When you're talking about internal carotid arteries and jugular veins and things like that, those feed different parts of the brain. So the symptoms will be different and they'll present differently. So if you're looking for some education on this, I can say, if you've ever heard of Coursera, they have Duke University has a medical neuroscience program that you can do for free. And a big portion of that in the early weeks of the online course is, looking at the vascular system of the brain. And they filter it through a medical lens. And so they'll talk about some of the symptoms or some of the motor neuron lesion signs that you may see with, vascular insufficiency in different part of the brain. So if someone's having a hemorrhagic stroke, like you said, they're not going to end up in a chiropractor's office. But some of these spasmodic, vasospasmodic types of ischemia things, they may. So anyway, these are rare circumstances, but in the event that in the course of your career ever, something like this wanders in, these are things to look for. And then also trust your gut. I think a lot of times, like you get the heebie-jeebies about some of these situations where you're like, this does not smell right, and trust that, don't not listen to it. And especially if it's someone and you've got a good rapport with, and they're not presenting like themselves. And other things that folks will often mention is like that impending sense of doom, right? They like to term it that way, but when people are having a vascular incident, they're gonna feel like something's seriously wrong. You know what I mean? It's gonna register with them in a kind of emergent way. which is why they probably won't end up in your office anyway. But
Well,
let's say it's one of these lifetime patients, and they love
yes,
coming to you for
yes,
everything. That's one of the situations where that might happen.
yes. That, and that's that, as you're talking about that, it made me think what's likely to happen is an established patient who you have a rapport with will potentially get in an accident, whether it be motor vehicle, trip and fall, sports or something like that. They're going to come to you first because they trust you, right? Um, as opposed to unless they believe that it is literally life threatening in the moment, they're going to go to the emergency room. But this is typically how things are probably going to present into your office, in that it's an established patient. They may have had an injury, either direct or indirect, or maybe they're an aging patient, especially for our folks that are Medicare. They see Medicare folks. That's where you're going to want to pay more attention, right? Sometimes symptoms that have crept up, sometimes symptoms that are acute, but for sure, the acute stuff of patients who are not established, that's probably not going to walk into your office unless you take walk-ins or crawl-ins, as they say. Um, but no, I think that's an important distinction to make. You're still, even with the people that that you like, and they like you still need to be on alert because this is stuff that can happen, and it's important to know, especially as people get more and more into sports and cars and these extreme type of things.
Yeah, and and I'm sure it's never your slowest moment, right? So if you're in the middle of a
Yep,
busy shift and something like
yep,
that comes up, it's like do yourself a favor and just pause
yep,
and maybe dig a little deeper. And I think if it's especially if it's someone who you have a rapport with and they trust you, they're not going to be mad at you or fault you for being overly cautious, right? Like,
yep,
but they will be upset if you missed out on an opportunity to save their life or to create, a more appropriate treatment plan, right? So
yep,
I think if because I feel this way too, like I don't want to freak them out. I don't want them to think they're having a stroke and go
yep,
through that whole experience and then find out that they're not.
yep,
But I would rather that be the case than
yep,
for you to brush it off as, well, that probably just needs adjusted and hopefully they'll be
yep,
okay. And then it hits the fan, and
yeah.
you're left holding the bag.
What is the 5 Ds? Dizziness, drowsiness, dysarthria, diplopia, and dysphagia, right?
Yeah.
That's posterior circulation. So that would be more of probably what we're going to see being close to the craniocervical junction as opposed to the ICA, which would be the anterior. Um,
Yeah. So
Dizziness,
these people
drowsiness,
they're not going to walk up with their arm curled up,
no.
right? But they may have been slurring their words. They may have been having double vision. They may have been
Yeah,
disoriented.
yeah,
They may have
fog,
fumbled,
yeah.
stumbled, that kind of thing.
That's important stuff. That's important stuff. Very important.
Cool. Yeah, and it's always worth mentioning in a conversation like this, just to give folks kind of the broad spectrum, because you know how it is. Like I'm sure I'll have people walk in here next week with cervicogenic dizziness because we're talking
Yep,
about it, we're thinking
yep,
about it, we're preparing for it, right? We're elevating our understanding of it, and so
yep,
you're more likely to probably experience it because
yep,
it's like anything. You get what you're ready for, or you get what you
yeah,
can handle. And so I think as we all talk about, well, we want to help, we want to help tough cases. We don't want to just work on musculoskeletal pain conditions.
yeah,
As we increase our understanding of these conditions and situations, I think you create more opportunities for folks that are suffering with them to get the help they need. So continue to pursue the knowledge and the education. If you have more questions about this type of situation or you want more access to information or resources, by all means, reach out and let us know, to Dr. Beard or to myself. Email blairchiropodcast@gmail. Also get in touch with us via social media or other outlets and say, hey, I'm really interested in this topic. I want to go deeper. I want to know more. We're happy to connect you with resources to be able to do that. And I will make sure that the papers that we're referencing and some of this, some of the technology that he had referenced, we'll put the links for that
yeah,
in the description of this episode. So you can go look at those glasses. You can look at even some of the more fancy diagnostic tools, whether it's right eye or B tracks and all this other stuff that can get integrated. I'll make sure that's all there for you to explore. My thing with technology is like, there's the shiny object syndrome. It's fun to get a bunch of tools, but let's be thoughtful about, how we're going to use these tools realistically and
yeah,
how meaningful are they going to be, for our process, both understanding our patients but then also educating our patients and helping them understand, what's going on with them. So I guess what I'm trying to say is don't go get a bunch of stuff just so you can sell people more chiropractic care.
Yeah.
Get clinical tools for clinical reasons, I guess I
Yep.
should say. So,
Well, not, the low tech versus high tech. Low tech is great. It's easy, it's inexpensive. You don't have to necessarily charge patients for the usage of this tech. But at the same time, the high tech stuff, there's pros and cons to that in terms of the more high tech stuff you're going to get, the more you're going to have to know
yeah.
about how to interpret that information. So you're going to need the education, you're going to need that understanding so that you know what the heck you're looking at. There is one thing, and we spoke about this offline, but this is something that I've been seeing, and I think that this is probably going to come to pass. We are going to see more and more vestibular function, and the reason I say that, in my belief, is multifactorial. One, we know that the musculoskeletal system feeds into the vestibular system. The more deconditioned we get, the more potentially we are going to be at risk for some type of vestibular function, proprioceptively, from your ankles to your upper neck, right? Two, we talked about how some of this cervicogenic dizziness can come from the neck in terms of maybe they haven't had an injury, but maybe it's deconditioning or fatty infiltration, which will probably be talked about in a later podcast. We're going to see this more and more as we become more sedentary and more remote, right? I'm not saying that people need to go out and start doing CrossFit, but at the same time, for the young doc or the seasoned doc or the student, you're going to be seeing this. And maybe it's cervicogenic, maybe it's not. But you need to know what you're capable of and when you need to get this person out to someone who is going to better treat them. Um, I think a better understanding of this is going to help people, patients, and doctors. It's not going to be information that you're going to regret having. So I would encourage the young bucks out there to get a little bit deeper into this. It will pay off. I can promise you that.
Well, and if you're an upper cervical purist and you'll never do anything but adjust C1 or C2,
Yep.
that's great, and I
Yep.
think there's definitely a place for that. But this will also help you, network with providers and help, because here's the thing, like other healthcare providers don't know this stuff,
No, they
right?
really don't.
And like patients do, they make an assumption that the physical therapist knows, or that the ENT knows, or that the neurologist knows, or that their primary care provider knows, and it's not the case. And so we may be the only person who will identify this, take the time to identify this and educate both the patient and a provider team on, hey, because I've talked to other healthcare providers, they get freaked out when dizzy patients get into their clinic because they don't know what to do with it, right?
Yep.
And so if you can help them understand, like, hey, this is likely a cervicogenic dizziness type of situation, discuss those history things that we talked about in the beginning, ask them these questions. If they answer yes, send them to my office. I can help them the best. I
It's
mean,
great.
there's huge benefit there. And so learn some and share some, and,
Yep.
and create more inroads into your office through other healthcare providers too, by equipping them with this information. And it's like a lot of things. As you teach others, you get to know it a little bit better. So get some information and some knowledge, share it, let folks know how you're able to help. And, I think it's
Infomolage. I like that. You were
knowledge.
infomolage, information and knowledge. We're gonna coin that. I like it.
You heard it here first, folks, on the Blair Technique podcast. So like and subscribe. Um, Hey, by the way, if this kind of content is valuable to you and you want to hear more of it, please let me know. I do take, when I do have listeners reach out and say like, hey, that was awesome, or they share it on social media, or that stuff I notice, and I will go with what you guys want. So for what it's worth, keep in touch and let me know, what you like and how we can better support you guys in your development. Um, any last words, Doc, as we kind of wrap up for this particular episode? Closing thoughts, remarks that you'd like to leave the listeners with?
No, honestly, like I will go back and re-listen to this probably several times. This has been good. This is a good one. I'm very proud of this one right now. If you want more, yeah, like reach out to both of us. But if you probably already follow Dr. Stenberg, you can follow me on social media. A little bit more active on Instagram than anything, at Dr. Bearder, Dr. Bearder. I like to post a lot of things pre and post results, different case histories, things like that. We have some really cool tech that we're going to be implementing. We will be one of 13 in the country that are going to be doing this. Super excited. It will probably directly tie into cervicogenic dizziness. So look out for that. But no, I'm loving this one. without the McDonald's. So
And he references a couple times, but just in case you guys missed it, Dr. Beer will be one of the keynote presenters at the Blair Annual Conference at the end of September at Green Valley Resort in Las Vegas this year. So if you haven't signed up for the conference, the lineup is out. It's not a secret at this point, but Dr. Bearder will be sharing. Dan Murphy will be sharing. I mean, it's going to be locked and loaded for this
yeah,
year. So definitely get yourself out there. Get your seat at that table, because it's going to be, really building you up in a lot of these areas. So that'll be my shameless plug for the Blair conference. The registration's live at blairtechnique.com. You don't have to be a member. You don't even have to be an upper cervical doctor to come and learn. So I think it's worth, if you like this kind of content, I think it's worth getting FaceTime with us at the conference.
absolutely.
Good deal. All right. Well, thanks a lot, Doc. We'll continue the conversations in the future. We're going to continue to have these type of episodes come out and build on this information in the future. So
Absolutely.